Welcome everybody to today's CRCC Seminar Series event. We're really very lucky today to have with us Dr. Katie Featherstone, who's going to be delivering a talk on, I believe, the topic of an upcoming book or a new book, communicating the rules of the acute hospital ward to people living with dementia and its consequences. So a few bits of housekeeping before we begin. Katie's going to speak for kind of 30 to 40 minutes, at which point we'll open the floor to questions from you guys. What would be great is if you have a question and you feel comfortable to do so, please do unmute your mic, come on video and ask your question directly so Katie feels like she's having an interaction instead of just talking to a screen. That would be wonderful. Of course, though, if you're having a bad hair day or eating your lunch or whatever, questions are very welcome in the chat too, and I will field those and make sure we answer as many as we can. Obviously, throughout the talk, if you could keep your microphones on mute, but equally, if you want to have your screens on, that would be great. So again, we have a sense of an audience and Katie's not just speaking to a screen. So with that said, as I say, Katie's presenting today. She's a sociologist of medicine and ethnographer, and importantly, her book has just been published, or is shortly to be published, sorry. It's available now to pre-order on Amazon, and I will post a link to that pre-order on Amazon in the chat, but also it's available open access online. So I think Katie can maybe give some more details on that. But without further ado, I will stop talking and hand over to Katie for her talk.
Brilliant. Thank you, Rachel. And I'm just going to try and see if I can find my share screen. So let's see if I can is that coming up, Rachel? No, hold on.
Not just at the minute, no.
Oh, here we go. I've got it. How's that?
Excellent. Yeah.
Yay. Great. Let me just do it on a full screen.
Fab.
Wonderful. Well, thanks for inviting me. And also, I'd like to say thanks to Paula Salco in your department, in your centre, because we've known each other a long time, and it's something that we keep trying to collaborate. We're close to collaboration, and I hope we can make that happen. Because I think there's a lot of synergy within my research and your department. I'd also like to say that this type of research that I'm doing, by its very nature, is interdisciplinary. So I'd like to say that my colleagues, Andy Northcott and Lester, collaborations in my department, also colleagues in the field of dementia research. It's actually really, really vibrant and very friendly field. I work with lots of people living with dementia and carers who are named co-applicants on my grants. They are involved in the governance of the research and also participants. And also nurses. I work closely with Dementia UK and the Admiral nurses, particularly, who've really supported the research and helped me to really refine my findings. So what's the issue? Well, I think what's interesting is how enormous the population of people living with dementia is in our hospitals. They really are one of the largest populations. Typically, the level of people tends to be set as around 25% of all hospital beds of all inpatients. But actually recently that's really moving into 50%. And that's really over the last 10 years, this population has really, really grown. And also importantly, these are people living with dementia who have an additional acute condition. So they have a fracture, perhaps a hip fracture, an infection, and they need to be in a hospital. They need that specialist care. The rate of dementia and the cost has really also increased over the last 10 years. So if I just look at the latest figures on dementia care, the cost of dementia care over the last 10 years has risen from 1.2 billion to 2.7 billion. The number of people living with dementia in hospitals has increased by 150%, and their stays in hospitals has risen by 180%. So it's a massive growth in this population. And I think it's really not really recognised by public policy and by institutions that this is our, in fact, now our main population in our hospitals. So what's the problem? Well, I think the key issue here is we need sociology to look at culture, hospital cultures. So we have a decade, as well as these this level of increase in population. At the same time, we have a decade of reports, inquiries, and research that really indicates that this population have really poor experiences, poor outcomes, and really poor quality care in this acute setting. And really that tells us on some really critical things about the state of hospital care. Really, it tells us something really important. It tells us that these inequalities are really deeply systematic, but also they seem incredibly resistant to change. So we've had in this kind of decade, we've also had lots of interventions, but again, they're very local, they're very patchy. So we have a lot of identification and awareness schemes. We have really little that really tries to change care quality in a deep way. So we have these really little plasters, if you will, of interventions, such as butterfly schemes, signage, which I've written about. We have purple slippers, we have This Is Me forms, dementia friends, to really just kind of like almost signify these are people with dementia in our wards, to kind of help busy staff see people with dementia. But they are incredibly local, incredibly patchy, and really have done little to change care quality. So I think we can also see the ward setting as a setting that's really highly resistant to change. And also, if we want to make any interventions in this setting, we've really got to think about interventions that reflect work as done, rather than work as imagined by other people, by policymakers or by institutions. So that's really why we need sociology. We need detailed sociological work that can really look at culture. What are the cultures here? Why are they resistant? What's happening here? And how might we identify what's going on, why it's going on, and how might we try and change that? So in response, over the last 5 years, I've obtained quite a lot of NIHR funding to carry out detailed ethnographies. And really what I'm trying to do there, although these are looking at very specific aspects of everyday care, the first one looking at refusal as care as a phenomenon that everybody recognised was happening in this ward, and also then looking at continence care, again a really hidden part but really so crucial to high quality care. Really to look at cultures. What are the cultures in these wards? And to do that, Andy Northcott and I have spent time in 8 hospitals, 16 wards. We spent a year of our lives in those hospital wards, hanging out, observing care, shadowing nurses, healthcare assistants, following the day-to-day work of those wards, doing day shifts, doing night shifts, doing across shifts, really looking at the everyday world of these wards. What's going on? Why is it happening? And how might we change that? Wards are really interesting places because they are such a small microcosm of little worlds. If we go back to some really old sociological kind of early ethnographies of the hospital, which is actually really interesting because there are very few detailed ethnographies of hospital life. But if you go back to the ones in the 60s and 50s, really they see wards as tight little islands where a patient is cut adrift from the world. Goffman describes wards as little islands of vivid and capturing activity within this wider total institution of the hospital. Hospitals also reflect the wider social world, and Calder describes them as a small society. And Rothanetti, who I've got to say I particularly love, if anybody is interested, I'd say this is the best. Let me see if we find the front page here. Rehabilitation for the Unwanted is just a masterpiece. I just think of all the ones I've read, of all the ethnographies, I think Rehabilitation for the Unwanted is the most powerful. And actually, yes, it was written in '67, but it could be a hospital ward now. That's what when I talk about cultures, I think you start to see where I'm heading here. And I think one thing that we found was absolutely people living with dementia are cut adrift on an island within these wards, but they also absolutely reflect society. People with dementia and the wider understandings of dementia really are alive in these wards. You would expect maybe a more kind of clinical understanding of dementia, but actually social understandings of dementia are powerfully enacted in these wards. And that's my little book collection of the classics that I went back to. And as I said before I started my talk, I've been doing a lot of writing. And part of this writing, obviously, we have to do it. We need it for ref, we need it for our reports. But also it's about the level of writing required to really understand these cultures. And there are so many ways that I can tell you this story, and there are so many stories within these hospitals to tell that actually have really powerful impacts on people living with dementia, but also on ward staff. And there's so much more to do here. It's a really, really vibrant area with so much research that needs to be done. And today, I'm just going to take one slice, and in fact, it's something that goes through my monograph, Wandering the Wards, and we do have one chapter that really looks at the rules of the ward. But I really want to just take that as a snapshot of just showing you the rules of the wards and how they impact on people living with dementia and how vibrant and powerful they are. So, understanding the rules of the wards, but of course every institution has rules. We know as soon as we go into a school, we go into any workplace, you feel those rules, you feel them alive, you know you have to understand them. And of course, we all have to learn those rules. And in hospitals, that's just the same. We have to conform to the rules, restrictions, and freedoms of the hospital. And as Rothanetti notes, if a patient is new on the ward, he must be taught the customary behaviours and orderings of relationships. And we also found patients actually were asking quite often about the rules. What are we allowed to do here? And we also found yes, I'd say we found it very powerfully in the kind of the first ward I went into, and I'd actually never been into a hospital ward before. Very powerfully, that sense of not belonging. But every ward I went into subsequently, even a year of going into hospital wards, that last one, I still had that uneasy sense of not belonging as I walked through the door, that I required permissions. Was I allowed in here? Wasn't I? Where should I be? Who should I talk to? Where was I allowed to go? That real sense of uneasiness of what's allowed here. Am I trespassing? What are the rules here? And it's powerfully felt by everybody in these wards. So I'm going to take you through some of the key rules that we identified. There are so many rules in hospital wards, but some of the key ones. But I think what we found so interesting was how compulsive the communication of these rules was when it came to people living with dementia. They were compulsively and explicitly reinforced and emphasised to people living with dementia. There was a lot of repetition, And also there were a very limited range of responses that were acceptable and that were viewed as in accordance to these rules when it came to people living with dementia. So it was a very little room for flexibility in both how staff felt they could communicate with people living with dementia, but also how people living with dementia were allowed to respond and to act in these wards. And we found there's lots of kind of tightening and rigidity of care for this group, particularly if they started to not conform to these rules. You could see a tightening and rigidity of care for individuals, but also for groups. And we found this really went way back to a sense of the kind of permissions and privileges, which goes back to Stanton and Schwartz of the mental hospital, Goffman, of course, in asylums, and Julius Roth in 1963. So the sense of who is allowed to have permissions to do certain things and who has privileges was really powerfully felt and enacted, and very clear, particularly for people living with dementia. And it'd be interesting if you want to put in the chat if you have been in hospital wards and you have a sense of actually that was a really big rule when I was there, or other rules that we might not have picked up on. So if you can think of any of your rules from your admissions, they'd be really fun to hear about them. So here's an example. I think this was on my first day that I spotted this. I think any ethnographer out there will know that the first day is where you see suddenly everything. It's an overload. You see so much, but it's also a point where you can really see some key themes that actually end up running throughout the research and become quite big in the analysis. So here we have, I'm shadowing a healthcare assistant, and she wakes up a patient for her observations and medications. As she does this, a younger man from the low dependency bay at the end of the ward walks past. He's just wearing his underpants. He's holding a wash bag in one hand and pushing his mobile drip attached to the IV port in his arm in the other, as he heads down the corridor to the bathroom at the end of the ward. So you can see his privileges. He can saunter down the ward in his pants, all good. At the same time, Kathleen is getting up from her bedside chair. Kathleen is 87 and was admitted with a fracture following a fall. She also has a diagnosis of dementia. Today, Kathleen is wearing a full-length dressing gown that's buttoned all the way up to her neck. It's in the middle of summer and very hot in this ward. It's quilted in a soft purple fabric with tiny sprigs of flower like heather all over it. As Catherine does this, the healthcare assistant calls over to her, "Where are you off to?" She responds that she's heading to the toilet, which is across the bay on the other side of the corridor. This is about a couple of yards. And the healthcare assistant is relieved. "Oh, I thought you were going to escape." She goes over and helps her to reach her walking frame and stands closely behind her as she quietly murmurs, "I know, I know, I know, I know, I know," closely shadowing her all the way to the bathrooms and back. Afterwards, she turns to the healthcare assistant and smiles and says, "Thank you so much." As a young man from the bathroom walks back to the bathroom, he's still in just his underpants, and the healthcare assistant gives me a look. So you can see here who's allowed to have privileges and who isn't, who's closely monitored. And of course, there are reasons for that monitoring in some ways. You know, staff are very worried about risk, worried about falls, but this was a very different, close sort of monitoring. So rule 1, everyone living with dementia must understand you are in hospital. Okay, this was rigid and highly repetitive repertoire of tactics and performative work at the bedside that we found. There was a real reliance on these stock phrases, simplified language, slowly enunciated, delivered in a collective institutional timbre, and the special tone of voice of the total institution. All of this work really was locating and reorienting people living with dementia to being within the institution and to recognise this fact. So we had, I'd say, every member of staff would say this at some point to a person living with dementia. During every single hospital ward we visited, this is a universal. You are in hospital. Which, as you might imagine, is not always the most helpful thing to be told, but there was this very rigid and structured approach to talking to people about dementia, talking to people living with dementia. Very simplified instructions: sit in the chair, sit down, you've broken your hip, you've had a fall, so what has happened and why? It was very, very limited talk, really restricted. Also, you must not wander. Instructions were really around, you must stay in bed, you must stay at the bedside. These typically contained really powerful sense of urgency that often displayed really deep anxiety of staff about people with dementia walking and potentially wandering. Repeated warnings emphasising risk, imminent danger, the likely consequences of the behaviour if they fail to comply or modify their behaviour. A particular concern, as I said, is about the risk of people with dementia falling, having a fall, or absconding. These were all phrases repeatedly used by staff. So nobody was considered to be walking or taking a walk or you know, just actually walking in that environment. It was always phrased around absconding, wandering, falling risks. Also, the importance of Rule 3 is about you must communicate your needs verbally. And staff really focused on repeatedly reminding people living with dementia that they must use institutional forms of communication. They must, you know, tell us when you need something, tell us when you want to get up, tell us when you need the bathroom, and also use the bell. So again, while staff could respond to requests verbally, the most powerful way to get attention is using the bedside buzzer. But actually that was really difficult for people with dementia to use, and also lots of people were unable to communicate verbally or didn't feel they could, particularly if you see these are people living with dementia but also an acute condition as well. So instead, people living with dementia typically communicated in embodied ways, and there were really subtle signs, but actually if you looked you could see those, because they might start off being subtle, but they could also quickly become more visible and more powerfully felt. So people looking uncomfortable, looking distressed, potentially defensive or rigid body language, repetitive behaviour, becoming very silent and withdrawn as well. And in the fast pace of the wards, they could become really lost, but also forms of communication that the staff really felt unable to respond to. And of course, if this was unrecognised, this could really escalate and people could become very, very distressed very quickly. And care must also fit the timetables. Staff had a powerful sense of falling behind and the fear of falling behind. Timetables were powerfully felt. And there were also, while there were timetables within the wards of the schedule of bedside care work, there were also outside timetables that had to be met. So certain things had to be done before meal times, before the medical team's rounds, those sorts of things that also were powerfully felt. Staff absolutely really struggled with this, and there was always a point during every shift where staff felt they were falling behind or were falling behind, and really then they started to really ramp up the pace of care at the bedside. So this could include, you know, use of bargaining for future activities, visits for family, you must do this if you want to go home, looking nice for visits, being dressed for meals, or submitting to interventions were all common inducements. And care outside of the timetables was really seen as a source of disruption, added labour and disturbance. That goes back to Roth and Eddy in '67. But actually, if we look at a lot of recent nursing papers looking at wards, at nursing care, they come up with very, very similar findings, as did we. These feelings that staff, that people living with dementia must fit into the timetables was powerfully felt by staff, but also they felt they had no option either. You know, we have to change you, we have to do this, we have no option either. The timetables of the institution were really driving everybody here. Rule 5, no personal possessions. Although in some wards you could see attempts at supporting people to be dressed in their own clothes, actually it always reverted back to these very old practices of stripping. And this goes back to 60s hospitals and earlier, really dressing everybody living with dementia in hospital issue gowns, pyjamas, and also socks. Some even had socks that identified people as living with dementia, the purple socks. Possessions always placed out of sight within the bedside lockers, which were often locked, inaccessible, and that actually caused a lot of stress and anxiety. While staff were doing that to keep things safe, neat and tidy, this was powerfully felt by people who were not able to access their things. And this extended to, there's an awful lot of dementia-friendly resources and rooms in these hospitals now, but they are always unused. They are neat and tidy and pristine, and there's something about them. They must not be used. They must be kept perfectly in their boxes. So there's something also really powerful about that needs to be explored. Rule 6, you must follow etiquette and bodily discipline. So it's a really powerful driver of cleanliness, bodily discipline, but also about discipline, actually even in particular, it became very, very narrow, this kind of tightening of the rules really around etiquette was powerfully felt and asserted over people living with dementia. So for example, this could extend well beyond whether a person should be supported in eating a meal to really asserting control over how they eat it. Staff really emphasise the ward requirements, the institutional requirements to maintain the correct order and routine of mealtime. So for example, if people were eating their dessert first, that was a real problem. You must eat your main course, you must eat your soup first. There's a real thing about soup in hospitals. There's a whole other story that Paula and I are trying to work on, but that's for another day. But I think here's a great example of how actually these sorts of things actually really become a way that the wards start to see people living with dementia in certain ways as they use these rules to guide them. So here, a healthcare assistant begins to cut a patient's food up for him while the team of doctors approach his bed and question him about his meal. The patient says to them, "I can't eat that, it's no good." The doctor tells him it's warm. Another doctor, in an overdrawn, slow, loud voice, tells him, "It has been cooked." To which the patient responds almost sarcastically, "I know that, but it's gone cold." In response, the doctor begins to assess the patient's capacity, asking him questions about where he is, which he's able to answer. The doctor seems insistent on using the loud, slow voice as if the patient is deaf, which he isn't. He's been holding normal conversations throughout the day and speaks using appropriate tonal variations to express himself. Once the assessment has been completed, the team of doctors make a big fuss about this patient eating some more, despite him having eaten more of his plate, a roast, than the patients in the neighbouring beds. And this is just a tiny excerpt because this continued for quite a long time, where this plate of cold food remained in front of the person and he was really expected to eat it. And being cold was really not seen as being valid, but also the doctor started to seem to question his capacity around this issue. So food became a really interesting area where if people didn't eat in the expected ways, you would get this tightening and seeing them in very particular ways, and really concerns about their dementia increased. So why are these rules important? Okay, because they really demonstrate ward understandings, institutional understandings, wardens understandings, and also staff understandings of dementia. In the ward settings, dementia was really seen as a cognitive deficit that required continual orientation, verbal cues, compulsive repetition, as if that would really remind them of the behavioural norms of the institution. And this could really start to get very, staff could become very, very anxious about this, and really this repetition could repeat. There was no sense of any other ways to talk to people other than this very narrow repertoire of talk. A person living with dementia who emphasised their wishes, rejected the timetable, or wanted support outside of the timetable order was really viewed as potentially problematic and could become a really serious concern for staff. They could become seen as someone who was, their dementia was more severe than it actually was, and they could also be seen as willfully rejecting the rules of the ward and the ward staff themselves. So you've got these kind of two levels of, at one level, it was recognised as behaviour that really emphasised their dementia and meant they had no capacity. But at the same time, this sense of willfulness also seemed to suggest that actually staff also saw them as active agents as well. So you got this going on. So there's no real room for people living with dementia to be accepted. It was very much those kind of two ways of seeing them. And again, this really reinforced understandings of the condition, recognition of individuals, and commonly accepted notions of who this group were, and really that they did not belong here. So I think that's really the heart of this issue. As I said earlier, these are one of the main populations in our hospitals, but there's a real pervading sense in these cultures that they just did not belong here. There might be somewhere else that's better for them, but not here. We also found there was very little change of the emphasis from doctors' orders. And I think this hadn't really changed from going back to the ethnographies of the institution in the 50s and 60s. Conversation or listening to patients appeared to have no recognised organisational value or status within these wards. And that really reflects those long-standing institutional cultures. Patients living with dementia were very powerfully restricted, but also staff, ward staff were also powerfully restricted. And I think one thing I felt from all of this is that both groups are really suffering in this situation, in this context. And the key impact of all of this containment, all of this enforcement of the rules was the use of containment, restriction, and restraint. And in fact, we found high levels of restrictive practices being carried out in the care of people living with dementia. A lot of this undocumented. It's been a bit of a controversial finding, but I really want to do some more research to look at this in more detail. But this was something I really did not expect to find. I went in there, I suppose, very naively, but actually we found this was the key mode of work in terms of caring for people living dementia, to fit them within the timetables. The tightening of rules and restrictions really resulted in containment and restrictive practices. That could be raising the sides rails of the bed, but also could be and other furniture, but it also could be clinical technologies, including continence technologies, the use of continence pads as routine, and tightly securing medical equipment. But there are also specific technologies to restrict people, such as chair alarms, and also different groups brought in to do that. So one-to-one care and specialing was also used to restrict people to the bedside. And I'm not going to go on to that too much, but I just want you to think that actually, you know, there was, while staff typically saw, and the institution of the wards saw people's behaviour as being a feature of their dementia, not fitting into these rules, not responding appropriately, actually we found it was a reasonable response to a very abnormal setting, where actually the expression of distress and protest was perhaps a normal reaction to this setting for very sensitive patients. And this goes back to Menzies' list in the 1950s, talking about anxiety in hospital wards, and we found our work really reflected her findings. And I'm just going to end on the key point I want to make here is we really found institutional cultures of looping. This goes back to Goffman, but also Hacking within the total institution. An agency that creates a defensive response on the part of the inmate takes this very response as a target for its nexus act. So we've got these tightening and responses of, as soon as one person living with dementia became anxious or distressed because of everyday care, actually that became something to be managed, to be restrained, to be restricted. And this could escalate very quickly. It could escalate from one person, but also could escalate across the wards. And you get this kind of communication, repetition and restraint of these rules, and tightening of these rules. And I know I'm running out of time now, so I'm just going to end on just saying that we do a lot of work on involving and including people living with dementia within our research. We work hard on knowledge transfer and trying to inform public discourse around this area. I'm working closely now with public policy, particularly Welsh Government cross-party inquiry on dementia care in hospitals. And at the moment, we're looking at the impact of COVID and hearing testimony from a lot of people living with dementia who've been in hospital wards during COVID about their experiences, which I think suggests an escalation of what we found rather than a reduction. We're also delivering training, working with the Open University to do open access training for ward staff, using our ethnographic findings, working with nurses and people living with dementia. We've got new grants under submission, one looking at diagnosis and screening, which I think is a really under-examined area in hospital wards, and also looking at restraint in more detail. I also run a network for career dementia researchers, doing monthly online support to support them in leading their first grant as PI. Thank you. Now, Rachel, I need to hand it back to you, don't I?
Yeah, if you just click the stop screen share, then perfect. I think, thank you so much, Katie. That was fascinating. For somebody who sits outside of this area, maybe you could see my face changing as we went through. I'm going, wow, didn't know a lot of this stuff. So I'm sure everyone else concurs. So the time for questions is upon us. So I think, as I said at the beginning, what would be great if you want to ask a question in person, if you just use the raise hand icon on the bar within your Teams, that will let me know, do you want to speak, and I'll hand over to you. Otherwise, if you just want to type up a question, pop that in the chat, and I'll field those too. So, oh, we have a question already. Liz, please, over to you.
Wonderful, thank you. It was really, really interesting, detailed, but rather bleak picture of our contemporary hospital settings that you presented for us. And I wondered, Kate, whether whether there were moments which kind of disconfirmed your overarching impression. So I suppose kind of deviant cases where you saw things that gave you hope for positive change in this setting. And also, I guess, related to that is how, when you're engaging, particularly with frontline care workers, how you communicate that context to them in a way that would empower them to effect change in that setting.
Thanks. That's a great question. It's really important. I know it is a bleak story. You know, it is. And I think the key message I keep wanting to come back to is the institutional life of hospitals and hospital wards is really bad for two groups. It's really bad for people living with dementia, but it's also incredibly bad for ward staff on the front line in these wards. So for me, the only way that we can improve care is to improve the circumstances for everybody in that setting. Yes, we did find absolutely some great examples, and I would say that every member of staff that we observed really wanted to give high quality care, but were really frustrated. There is something about the institutional structures that are so powerfully felt and enacted within these wards. Is a really interesting place that actually, I think that's why a lot of interventions just bounce back, because you know, you can see, for example, things like lots of technology arriving into these settings. So you get kind of new mobile technologies for monitoring patients, for taking notes. Actually, they all get discarded really quickly. But in every ward, there's also this sorts of there's always a room or a part in the corridor which has a lot of technology that's just been arrived and has been discarded, covered in dust. So it rejects an awful lot in this setting. I'll give you one example that we have in our book where we saw some amazing care, where actually the healthcare assistants, they dusted off an old, well, a monitor that had games for people living with dementia, and they dusted off the monitor. It took them ages to get it to work because, of course, you know, the remote disappears and it's difficult, but they persevere. They get this working. They move everybody around to sit not next to their bed, but actually all together. And they all get engaged in this game that is about pig racing. And everybody's having a laugh. The patients living with dementia who'd been very, very stressed, who were resisting the medication rounds, actually relaxed. They had a laugh. The nurses were going round giving them their medication without any problems. It was all fine. But very quickly, there were subtle signs about the rules of the ward. So you get nurses passing that bay going, oh, is this supposed to be work? Oh, is anybody working here today? What are you guys doing? So then that's just from their colleagues. Then the nurse in charge of the ward walks past and she makes it very clear, this is not considered work here. Then the medical team arrive and the medical team go, what's all this mess here? And starts to apologise to visitors going, I'm so sorry about this. This is a terrible mess. Can you just, you know, why are all these patients out of bed? We're here to do our rounds. And the doctors are, you know, they move back, the doctors do their rounds and they leave the monitor off and faced away from the patients. They just walk away. And of course, those members of staff who were doing that amazing work never did it again. So that's how these cultures just push everybody into doing things in particular ways. There's very little wiggle room. These hierarchies of care are very powerfully felt and powerfully enacted. If I can't do that nice work, neither can you. But it really misses out this group. And then I think your other point is around how do we empower staff? I've been really clear doing all the research that actually when I'm in wards, I write up a bit of data and give it to them. So it's anonymized, but they can see the kinds of what I'm seeing, and they all go, yeah, that's me. No, that's me. No, it's me. They can, so try and engage them in the research, but also to say, absolutely, your work is so hidden and it needs to be made visible, and the struggle that you have needs to be made visible. So that's something that I've really tried to do, is empower people with the research, and I absolutely involve nurses in the research very closely.
Thank
you. Does that answer you? I'm just going to put my computer on some power, so I'm just going to find my, this is taking up more power than I thought. Any other questions?
Okay. Yeah, we have another one from Ruth, if you want to go ahead.
Hi, Ruth.
Trying to unmute, sorry. Yeah, I was, it's going along the same lines, really. You started these very patchy implementation of various initiatives, and that feels a very common picture. And I guess as you were talking about it, I was partly thinking about the delirium specialist ward at Queen's Medical Centre, and how they certainly aspire to practice very different to that which you were describing. But sort of in that context, I'm curious as to your thoughts about how change might be wrought through in a less patchy way. Have you had sort of thoughts about that? Are there examples of where practice has massively changed in certain areas just because of those, but and in a universal way, thinking about, for instance, how parents didn't used to visit children in hospital, well now they do, and the whole culture has massively changed in aspects of children's care. I was just curious as to what your kind of dreams are in terms of how things might be more broadly improved and impacted.
Yeah, I mean, this is the big question and big issue. Can we use sociology to change care? I hope so. I think yes, it is incredibly patchy. You can go into any institution and you will find some amazing care, absolutely. But it is absolutely remains very local. Even within an institution, you find one ward and then you'll go to the next one and it's completely different. And I think one thing that has to change is hospital institutions at the moment are still in absolute denial that people living with dementia are one of the key populations in our hospitals. So what you get is cultures of outsourcing. So when I told you about the group, the healthcare assistants who are trying to spend time with their patients living with dementia, actually communicate with them, support them, listen to them, that work is now outsourced. That work is outsourced to dementia-friendly staff, to dementia care workers who tend to be highly skilled, low paid, and there's only ever a handful to cover a massive 500-bed hospital. So they've got no space to really visit that many of the patients. You also have outsourcing to one-to-one carers when people are seen as being particularly problematic or their behaviour is seen as difficult. So you get a lot of outsourcing, which means there's very little space for ward staff to do that important work. So I think there's, on an institutional level, it's thinking about actually we need to support to really recognize the population. But on the ward level, my goal is to, and what I'm working on is thinking about those small changes that staff can do that really don't require permissions from the institution. How can we support ward teams to see the cultures and see how they can shape them and change them? If we just look at the timetables, it's incredible how that timetable really hasn't changed since the 50s. And in fact, there might have been a shift at some point in nursing care in the 70s, but actually it's now regressed back to a far earlier time. it's very, very rigid ways in which care is being delivered. So I'm currently working with Public Health Wales, and they've got an amazing innovation team, and they love the research that we're doing, and they really want to use that with at least with a couple of wards to start going, can we work with the wards to support them locally to make change? And if we can do that in a couple of wards, maybe that's something we can turn into an intervention or a support system that we can roll out a bit more. So I think it's almost those kind of like two levels we've got to go for. But you know, I think at the end of the day, we've got to support our nurses and healthcare assistants to really give the sensitive care they want to give, but are absolutely being denied.
Thanks.
Thank you, Katie. I think we have a follow-up question from that one from Paula, just asking, are the outsourced staff from private agencies?
Yes, not always, but you see an awful lot of outsourcing. So you've got outsourcing of one-to-one, it tends to be agency care, and that really is that's called enhanced support formally, but actually in practice it means you have a healthcare assistant who sits next to someone living with dementia and keeps them in the bed or at the bedside for 12 hours. So it could be an opportunity, an amazing opportunity to engage with that person and really support their recovery, but actually it really reduces because it's outsourced. The dementia specialist workers tend to be in-house support, but again, very few of them. So you get that kind of mixture of outsourcing, but also outsourcing from the ward. Yeah, it's other people can come in and do this work. You know, another rule of the ward is, you know, nurses and healthcare assistants must never sit down and must never sit down at the bedside. So, you know, you can see it's really funny. Sometimes you see people just sit down for a minute and then they just kind of jump up as if, you know, you can only sit down if you're writing notes. If you're writing up medical notes, you can sit down. But other than that, sitting at a bedside is not allowed. It's powerfully, powerfully felt.
Wow. Paula, you have a question.
Yeah, I've tried to be quiet because I know Katie's work quite well, so I hope that other people get a chance to talk to you. I have a kind of a, maybe, you know, some of my colleagues will answer this question, because I was thrown into the hospital environment where I've never done any work before because I did something on antibiotics. You know, I'm a sort of, I don't know, set in my ways medical sociologist that I always interview patients for whatever reason, because that's what I do. And then to my kind of great surprise, I found that there is huge amounts of research on antimicrobial stewardship and in the hospitals, and none of it focuses on the patients. And I was somehow kind of, you know, gobsmacked, because, you know, I always do that. And I was just wondering, when you talk about social sciences and sociology, that I almost feel that there is a bit of a trend to study the staff in order to improve safety and practices and so on. But somehow, you know, these older adult patients in particular, who are very tricky to interview, you know, right, because you're not quite sure what they are. But when you actually sit down and talk to them, they have a lot to say, and they're quite ironic about their care, and they crack jokes about what the doctors are doing and think they're doing and all that. So I was just wondering if there's a bit of a sort of like almost like a paradigm in certain kind of social scientifically informed health service research, where actually it's a lot easier to hang out with the staff. Because, you know, I was quite, you know, smitten by your work, because I could sort of identify, you know, with the patients not being listened to or fed soup and all these brilliant sort of like things that I know is in that material. But, you know, that's my sort of question. Or am I completely on the wrong track?
No, I think you're right. I think there's been an awful lot of silencing of the voices of people living with dementia, lots of assumptions made about their ability to absolutely communicate their experiences and contribute to research. I've got a lot of data on talking to people at the bedside, but one that was, I'd say, permissions from ethics committees to do that is also a challenge. So we have limited ability to talk to people at the bedside for good reasons, but also a sense that actually, because they're vulnerable, I think sometimes that vulnerability can be seen as actually reducing people's agency. So I think that's an issue. Yeah, I haven't reported that here because there's only so much I can just go on forever. But I think generally there hasn't been much research, particularly in hospital wards, of talking to people and really exploring their voices and giving them a chance to express themselves. And that is, it's partly ethics, but also partly researcher. So there's a bit of both there, I think. And I think when I first started doing this, I started working in the field 5 years ago. And I think back then I felt very uncertain about the best approach. I didn't know as many people live with dementia as I do now. So I think I started out with that kind of hesitancy myself. And it's taken me a long time to get to the point where actually now people living with dementia are absolutely central. They are co-applicants on all my grants. They are absolutely on my governance committees. They are central to everything I do. So I think it's almost the case, I think it's a field that's taken a lot of time. If we think about research in the field of mental health and that co-produced approach, I think the field of dementia still has a long way to get to be there, but that's where it's got to get to.
Wonderful. Do we have any last questions just before we wrap up? I might put a query to you if I could, Katie. It strikes me that as you were talking, I hadn't quite realised how frustrating the experience of being in hospital could be for those patients, but it makes me think more broadly about anecdotal evidence you hear about older folk going into hospital ostensibly to help them heal from a fall or to get better, and lots of them never leaving and passing away in hospital. So I just wonder whether there's, potentially there's a link between almost like a learned helplessness. It sounds like with assumptions made around the dementia diagnosis maybe, but any sense of independence taken away from these patients to the point that, if they have dementia, they broke their hip's fixed, they still can't go home because the things that they were maybe doing for themselves through practice, they've then not been able to do because they've sort of been infantilized almost.
Yeah, Rachel, you're absolutely spot on. There's a couple of things going on there. I think because culturally there's such a powerful sense that, people living with dementia, once someone is living with dementia, they're going to die of it. And that, the numbers that we read in the papers all the time about X number of, thousands of people who are dying from dementia every year, it's seen as almost inevitable. Yeah, this rapid decline once someone has dementia or once someone is in hospital. And I think that has really informed hospital cultures where there's almost now a sense of death is inevitable here. Because it happens, it's seen as inevitable rather than actually maybe it's around the way care is being delivered. So we got that really interesting tension of, what's going on here? What's causing this? Because absolutely we know just high levels of really, really poor outcomes for this group, which I really didn't touch on, but you're right. If you're living with dementia and you're in hospital, then your risk of dying is incredibly high. It's something like 25% are going to die during admission. The length of admission is going to be far longer. The rate of, you're less likely to be able to go home after that as well. And we've got lots of other things impacting on that. So you're right, it really does, the setting itself also really leads to a lot of deterioration in people. So the issues around you must not wander actually, and the use of restraint actually means nobody rehabilitates because they're just not able to walk. They're not allowed to walk. Staff feel they can't allow people to walk. It's seen as dangerous, it's seen as highly risky, and absolutely falls in hospital can lead to even more fractures and are also a risk of mortality, but it's taken to an extreme. And also it's a key metric for these wards. These wards, they have key metrics on their board that says how many falls this week. The goal is 0 falls. If you've got 0 falls, a board will be really proud of that because that's what the institution demands. But 0 falls means nobody will be walking, everybody will be in bed, and there will be deconditioning really fast. So that's how the institution is really pushing ward staff to care in very particular ways for this group. And also you'll have a lot more restraint as well. Yeah, so which won't be classified in the documents, it's just what happens. So yeah, Rachel, it's long-winded. All my responses are really long-winded, but you're absolutely spot on with that.